Good day. My name is Michelle Lavander. I'm the director of the USC Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, Trump's Return, What Comes Next for Healthcare. Donald Trump has promised to let his allies go wild on health with his return to power, and early indications are that he's serious. He has blasted the Affordable Care Act. Obamacare was lousy. Healthcare always was. It's not very good today, he said during the debate, before adding, we're going to replace it. There's a lot at stake. Healthcare as we know it could be imperiled for the record 45 million Americans who now benefit from the Affordable Care Act. That includes tens of millions who receive healthcare through Medicaid, the free program for low-income Americans, and the 21.4 million enrollees in state health marketplaces. Will Republicans seek to slash Medicaid funding and enhance federal subsidies for state healthcare marketplaces? They have made insurance affordable for many, but could add $335 billion to the deficit over 10 years if made permanent. Or would the new administration neuter the power of the CDC? And what will the so-called Department of Government Efficiency mean for key health programs and public health agencies? As Trump's transition unfolds, we remain in a position of tremendous uncertainty. Last week, we learned that Trump had picked Robert F. Kennedy Jr. to lead the Department of Health and Human Services and the TV personality Dr. Oz to lead Medicare and Medicaid. Both hold controversial positions that buck the scientific consensus. If confirmed, Kennedy could try to undermine evidence-based approaches on vaccines, fluoride in water, and more. It's still early days, and it's unclear whether the administration will be able to enact some of the radical ideas now under consideration. What's indisputable is that the Trump health and healthcare agenda has the potential to touch every American. Our distinguished panelists today are here to help us read the early signals and weigh in on what's possible and the stories that can be told. Joining us to share the latest reporting and help us to analyze these policy developments are Dan Diamond, a national health reporter for the Washington Post, who focuses on accountability, federal agencies, and public health. He joined the Post in 2021 after covering the Trump administration for Politico, where he won a George Polk Award for investigating political interference in the pandemic response. His investigations have delved into a range of topics, including Trump officials' use of taxpayer-funded charter jets and not-for-profit hospital spending. As a Center for Health Journalism National Fellow, he chronicled how Congress stripped Pacific Islanders of their health coverage, a project that also played a role in an act of Congress that restored those benefits. Joanne Keenan is the journalist in residence at Johns Hopkins Bloomberg School of Public Health. She writes about public health and healthcare topics and is a contributing editor to the Politico magazine, Politico Nightly, and a regular panelist on KFF Health News' What the Health podcast. She was at Politico for a decade, overseeing its health coverage from the implementation of the Affordable Care Act to the coronavirus pandemic. And she's covered health for Reuters on Capitol Hill previously for more than a decade. A graduate of Harvard, she's been an Inter-American Press Association Fellow and a Kaiser Family Foundation Media Fellow. At Hopkins, she's co-taught with Dr. Josh Sharfstein a course on how the political and economic changes in the U.S. media affect our health. Their book is due in 2025. Sarah Overmall is a Washington correspondent at STAT, reporting on the Biden administration's health goals, federal health policy, and politics. She previously covered health policy in the drug industry for Politico and S&P Global Market Intelligence. Before returning to her home state of Virginia, she spent 5 years in Dubai and Beirut reporting on business, finance, and development in the Middle East and Africa, including a 3-year stint as the editor of Banker Africa. She graduated from the College of William and Mary in Williamsburg, Virginia. This webinar is made possible thanks to the generous support of the Commonwealth Fund and the California Endowment. We'll be archiving this conversation later today at centerforhealthjournalism.org. A word about our format today. We'll be hearing from our speakers first, and then we'll turn it over to our audience for questions. Feel free to share general comments or questions in the Q&A. And because we have many people joining us, we'll ask you to write your questions for our speakers into the Q&A panel. You can also write us there if you're experiencing technical problems. Now let's get underway. Dan, let's start with you. Medicaid, the federal state program for low-income Americans, plays an enormous role in the health of the nation and our economy. It insures close to 1 in 5 people. Yet a discussion of Medicaid was conspicuously absent during the campaign. You've reported on how Trump's allies are eyeing Medicaid and food stamps for potential cuts to find savings that can make up for the costs of extending Trump's tax cuts. What are we hearing about potential changes to this massive safety net program? And what does news of Dr. Oz's nomination as the potential head of the Centers for Medicare and Medicaid add to this emerging picture?
Well, Michelle, thanks so much, and thanks for having us. Hello to all the reporters out there. I will answer the question, but just want to say it's fun to be on a webinar with Joanne, who hired both Sarah and I at Politico, and this is a rare opportunity where I get to hear from both of them at the same time. Also, I'm in our New York office, the New York office, the Washington Post. Great office. Could not find a box of tissues anywhere. So if I'm sniffling a little bit through this call, just know that it's because there's no Kleenex in our New York office. Okay, onto your important question. You asked about Medicaid and its conspicuous absence during the campaign. There was a lot that was absent when it came to health policy during the campaign. The Trump administration or Trump team didn't want to talk about healthcare for a lot of reasons. One being it didn't poll very well for them. But now that they have won the White House, that Republicans have Congress, I think many are expecting the return of Medicaid work requirements. This is the idea that if you are getting health coverage through Medicaid, you're an able-bodied adult, you either have to have some job or you're doing a significant amount of volunteering. That could come with an act of Congress. There have been attempts in Congress before at national work requirements. You referenced the reporting that we did recently at the Washington Post, me, my colleague Jacob Bogage, and Jeff Stein, on how Republicans are looking for ways to offset the cost of tax cuts. One way to do that might be Medicaid work requirements, which the Congressional Budget Office has said could save $100 billion, but also lead to 600,000 people losing coverage. So that is one potential Medicaid path. A second is CMS, the Centers for Medicare and Medicaid Services, giving states permission to impose work requirements. We saw that in the first Trump administration. There were 13 states that won permission, but it was mostly a failure. The various requirements got stymied, got challenged by courts. One state, Arkansas, went ahead with work requirements, and that did not seem to go very well. The courts ordered a reversal of that. Mehmet Oz, the nominee for CMS, has said very little as far as I've seen on Medicaid. Sarah and Joanne may know more, but CMS would be the agency awarding those waivers to states that would seek to impose work requirements.
And Dan, what did we learn from that Arkansas experience, for example, about what happens when a new requirement is added to a program like Medicaid?
We learned that it goes against the intent of Medicaid. The goal of getting more people to get jobs didn't seem to come to pass. There was some research, I believe, by Harvard's Ben Summers and colleagues that found a year and a half after the program had taken effect, there hadn't been a significant change in employment. The paperwork and the burdens involved with proving that you had a job drove some people away. A significant number of the people who lost coverage appeared to have jobs and just weren't able to prove it or didn't know that they had to prove it. And overall, about 18,000 people lost coverage over the course of 9 months. People who lost coverage had real problems getting prescriptions filled, getting their care paid for, they told researchers later. So on virtually all these counts, it was a failure. It was a failure at getting people to find work, and it was a failure as a health program. And I think that has hung over the specter of returning to work requirements. That, yes, it's something Republicans have talked about for years, but there's very little evidence that they work in the ways that policy leaders claim that they do.
Thank you. And Sarah, let me turn to you. Middle-class Americans currently benefit from subsidies that make insurance far more affordable under the Affordable Care Act when they purchase a plan on a healthcare exchange. But newer federal subsidies are set to expire at the end of next year, and many Republicans oppose continuing them. How important are these subsidies in making health insurance affordable for families? And what are folks saying might happen if they go away?
Well, there also just want to say what Dan said. Glad to be with my former Politico alums, but they're very important. These subsidies, the Biden administration has pointed to these subsidies for being big part of millions of people, record numbers of people being enrolled in the ACA program, and especially being important when we consider that the Medicaid enrollment was frozen during the pandemic, so people couldn't get kicked out of Medicaid. And then when that ended, a lot of those people had to look for ACA plans. And one of the things that's really important about this is that this kind of leads from what Dan was just laying out with what's been going on with Medicaid in a number of different states. The states that have not expanded Medicaid or essentially made more people eligible and done that with an incentive from federal government funds to do that, there's only 10 states left who haven't done that. Those states could be most vulnerable if these ACA subsidies that keep people's premiums, so their month-to-month costs low, if those end, people in those states will feel that most. And so when we talk about the specter of maybe ending these ACA subsidies, you have to think about who is going to feel it most, and then which of their lawmakers are going to have to answer for those changes. And so there's a number of states that vote pretty reliably red that will see the most implications from this. There's a lot of ways that Republicans are already talking about how they're going to cushion that, how they might not necessarily end those subsidies, but move them around in certain ways. For instance, through splitting up how those costs get distributed to keep costs low for people who are healthy and young and don't necessarily need to pay too much, but then also moving those subsidies away to high risk pools, essentially, to people who are chronically ill or older, and we know that they are going to have more costs. There's a number of ways that has been talked about, and I agree with both you and Dan that hasn't been talked about in so much detail, but we have some hints from people like Vice President-elect J.D. Vance, from some of the Republicans in Congress, and from some of the think tanks about how they would do this to separate these risk pools and to essentially retool the way that subsidies go. But I do think it's a political liability for a lot of Republicans to try and end these subsidies and then not work them out some other way to keep costs low for people.
And given the political landscape right now, how likely are these scenarios, ending or modifying the subsidies and adding work requirements to Medicaid, as Dan outlined?
Well, I mean, as I said, it's going to be a political liability for a number of Republicans, and you always see in any political atmosphere things start to happen in the House first. And so I think a lot of House lawmakers will be the people who have to explain first why they are making the decisions that they're making and how they are going to serve their constituents with that. With the Medicaid work requirements, what's interesting is that, I mean, Dan already laid out pretty well how that was happening in the Trump administration, but then the first Trump administration, but didn't go further. But we're already seeing where the momentum is building in a number of states. And so a number of states that were later to approve Medicaid expansion, for instance, approved it with some language that said that work requirements could be a part of that. And so we saw that in North Carolina, for instance. We saw that in South Dakota. South Dakota this November approved a ballot measure that would allow work requirements. So we're already seeing that momentum build up in states with regards to that. With the subsidies, I think that that's something that, I mean, as I believe you mentioned, this is going to be something they have to decide by the end of 2025, or no, before 2025. No, by the end of 2025, sorry. But that's going to be something where I think more realistically, Republicans are going to talk about how to move that money around differently, not necessarily eliminate those entirely, but how they can rework it into these things that have been somewhat vaguely talked about by Senator Vance or by other Republicans about how to separate risk pools and divide people into essentially different pools of insurance, keeping younger and healthier people into a lower cost pool, but then somehow trying to make that higher risk pool appealing still to insurance companies to cover.
And if you were a local or regional reporter, Sarah, what might you think about in terms of these subsidies and the possible Medicaid changes, is it too early to say, look for families who are receiving the subsidies or to go back to Arkansas and see what happened last time around? What would you recommend for our audience here?
That's interesting, and I'd welcome what Joanne and Dan would say here, because I don't think that many people know that they even have these subsidies in a certain extent. Like, this is not, people are not super literate in general on how the ACA works, how Medicaid works, how personalized these can be in their own states. But to reporters here who are thinking about state or local stories, those are very localized. There's different things happening in every single state. For the 10 states that have not expanded Medicaid, I'd say that this is absolutely a very high priority to think about how this would change in those states. But also I think that we've seen from the Medicaid disenrollment that happened post-pandemic emergency that a lot of people didn't know that they had to renew their coverage, for instance, that they had to do one small thing to keep themselves on the rolls for that. And so there's, I think, just a whole lot there that can be dug into.
And this is the technical term Medicaid unwinding that you're talking about, where people didn't have to prove they were eligible for Medicaid during the pandemic, but afterward they were asked to do so, and many people lost eligibility because they didn't take those steps. Joanne and Dan, did you want to quickly weigh in on some story ideas for this?
I think there's another issue with Medicaid. I mean, there's a lot of ways that the Republicans can go after Medicaid. I mean, one is work requirements, which we've talked to, but they could also restructure the financing. They could cut it. They could go to a block grant, which is something Republicans have talked about really since the Reagan administration. It's been a long-term unfulfilled goal. There are other things that you could do to cap the growth rate. So it's Medicaid spending is pretty open-ended. It's an entitlement. So there are ways that you could constrain spending, cap spending, limit spending. In addition to being across the board, less money for people who qualify Medicaid, the 40 states that have, I think it's 40, that have expanded Medicaid, many of them have triggers. Their state legislatures passed Medicaid expansion, accepted the ACA Medicaid expansion, but with a trigger, meaning that if federal funding was cut, the expansion would go away or be reduced. So there's that's something to look at. You know, if Congress does fundamentally restructure Medicaid funding, does Medicaid expansion go away in those states? And that's it's automatic. It's a trigger I forgot, I don't know the number of how, but in most of the conservative states that expanded, they do have this trigger. So, but remember, I mean, we learned this in 2017 when the Republicans spent, you know, an entire year huffing and puffing and failed to blow away, you know, the ACA. It's very hard to take away things. Not impossible. There are times, particularly poor people have lost benefits, but it's really hard to take away things from people once they've had it for a number of years. So politically, it is not, we don't know how slam dunk any of this really is. Work requirements is pretty easy particularly if they leave it up to states. Most of the conservative states would allow some form of work requirement from what we know so far, and we expect the courts would uphold them this time. And Dan has described the repercussions. But I think Medicaid is a real, because there's been so little discussion about it this year during the campaign, there's a lot of unknowns about what they would try to do. Maybe some things that we even haven't heard about. The ideas I just mentioned are all things we have heard about over the years. They could have.
And
Some other, Elon Musk wants to, you know, cut the federal workforce by whatever percentage in spending. It could really hit safety net programs, you know, including the VA and other things in ways that would be quite extreme.
I'd add just one quick thought on that even though there has been a lack of detail on Medicaid and on healthcare plans in general, from both Trump and from his nominee to lead Medicare and Medicaid, Mehmet Oz, I think it was very notable that Trump, in his announcement of Oz as the nominee, said that this is like, I don't have the quote in front of me right now, but this government agency is one of the biggest spending agencies. And it seems that he's alluding to costs being cut, and he's promised during his campaign that he would not cut Medicare. So the answer's there.
He has frequently said he won't cut Medicare or Social Security, and that leaves Medicaid. And he has not said he won't cut Medicaid. So Medicaid is vulnerable. But I would also point out, 1 second, Dan, is Medicaid is popular. You know, it's much more popular than it was in past decades. It covers a lot of people. It covers a lot of nursing homes and long-term care. It provides a safety net for people between, you know, when they hit hard times during recessions and they lose their jobs and they still have coverage and then they get another job and they get insurance back. The politics of Medicaid have changed. Dan, you wanted to say something?
Well, I agree on the politics and the population. I think when Trump took office January 2017, the population of Medicaid and ACA was maybe around 80 million combined, and now it's 100 million. So even more people, and the polling has only gotten better for the ACA. But this idea of what Oz might do and Trump might do, I actually think there's another path beyond Medicaid. And Sarah, this is close to your world because I was cursing Stat News for scooping me on this, but the idea that they might change how Medicare pays doctors, that has been seen as an area for reform. Any moment now, a Washington Post story should go up about that too. But the idea that there are ways to reduce payments from the agency that might not be as painful for enrollees. And this was the argument from the Biden administration too. We're paying too much on drugs, so we will cut what we pay drug companies, and that will actually benefit taxpayers long term.
And I wanted to go back to this thing you mentioned, Joanne, the block grants. And it's just such an abstract concept for an ordinary person. So how would that translate into what someone could expect on Medicaid for their health care? And also, you know, one of the other things that has been enshrined in the ACA are these protections based on pre-existing conditions. So maybe walk us through those two and what could change or not change.
Medicaid is an open-ended entitlement. There's no Medicaid budget. It's like, okay, we're going to meet the health needs for the eligible people. What the Republicans have suggested, there are various formats. One is a block grant, another they call it a per capita cap. I mean, there are various fancy words for it, but basically it means it's no longer an open-ended entitlement. It'll be limited, and its growth rate would be limited, so that states would have a smaller budget. Medicaid is a joint, most of people watching know this, but Medicaid is a joint state federal program. There's a lot of flexibility in how states can design their programs. Even without waivers, there's flexibility, and then there's a lot of waiver opportunities. State Medicaid programs look quite different. The federal government pays more than half of it. I think it's around 55% for the old traditional population and 90% for the expanded population. I may be off by a few percentages, someone can correct me, but the bulk of this federal dollars. And if there are fewer federal dollars, the states are not likely to make up any shortfall from the feds. The feds are the primary funders. It just means less Medicaid money and less Medicaid, particularly our economy goes up and down. There are cycles. There are times when Medicaid enrollment goes up because unemployment goes up, and then people lose their jobs in Medicaid, you become Medicaid eligible, and then you get another job that, hopefully, and you go back to, getting insurance in some other way. So it's basically less money and the states have to match some of the federal funds. It's all complicated, but the bottom line is less money and a slower growth curve, both. So you have a cut, and then you won't be going up as much on a yearly basis. And what was the other question?
Pre-existing condition protection.
Well, Sarah was talking about that. I mean, the two things that saved the ACA from repeal in 2017 were pre-existing conditions and Medicaid. Right? Those were the basic. People really it was popular that you're not discriminated against if you have a pre-existing condition, because tens of millions of Americans have some kind of pre-existing condition. And the older you get, the more likely you are to have one, or 2 or 3 or 5 or 20. So insurers used to be able to deny coverage. Even if you were healthy that day, if you had something wrong with you in the past, they could either deny coverage completely or charge you a lot more, that they saw you as a risk. The ACA did away with that. It put everybody in one gigantic risk pool in the exchanges, and there's some variation, but basically sick people and healthy people of the same age didn't have to pay different prices. What they're talking about now, as Sarah was describing, is creating risk pools so that the healthier, younger, healthy, older, sicker, under 65, under Medicaid. And they say, oh, you'll still be guaranteed coverage. There'll still be coverage for pre-existing conditions. But the question is, will it be affordable? If the idea is to save money and to have the government spend less on the ACA, you need a lot of money to cover sick people. Right now, the ACA has spread out that risk. This segments it again. So you can still have the law can say you can't discriminate. You have to offer coverage to people with pre-existing conditions, but you don't have to make it affordable. Before the ACA, states that experimented with requiring coverage for people with pre-existing condition without a lot of money, it was a disaster. It just made costs just went up. It was a death spiral, insurance death spiral. So it's, all the ACA subsidies don't go away. The ones that are easy to go away because they just expire. That's what Biden did. It's called the enhanced subsidies, and it's for people a little higher up the income chain. They got covered during the Biden years, but those are the ones that expire. There were things in that enhanced subsidy law that also affected lower income people. So everybody in the ACA would be affected, but Congress doesn't have to act, right? They have to act to renew them. They don't have to vote to expire them, because they're not permanent. They're through 2025. It'll be fairly easy for Republicans to, again, I think none of us know what's going to happen, because with Trump, even if he had a crystal ball, it wouldn't really mean anything. He's a very unpredictable president. We learned that last time. Sometimes he would announce 3 or 4 health policies in a single day. So contradictory ones. I mean, it's very hard to really know. And he's got a lot of things he wants to do outside of healthcare too. I mean, pretty much everything. He's going wild everywhere. So how much healthcare will be a first priority, how much they want to tackle other issues and then come to health, we don't know yet. So how this all plays out on the congressional calendar, Sarah and Dan are actually much closer to the congressional calendar than I am nowadays, but I don't think they know what's going to happen first either.
Well, and I know we have to get to other topics, so I'll be quick here, but just to what Joanne was just describing with risk pools and all this, and I know that this is very wonky, so if people want to talk about this more afterwards, we can, but one of the ways that Vance seemed to allude to them trying to control costs there and trying to basically keep premiums low for those higher risk or chronically ill people was a form of reinsurance. And we don't have time to get into how reinsurance works, but that seems to be the way. And one of the ways that they are floating how to control costs and potentially reallocate those subsidy dollars. So I think we can think about subsidies as maybe not entirely going away, but how they would be reworked in a certain fashion.
But it's really expensive to cover sick people if you're not spreading the risk. So even if they put some money in there, until you really see the figures.
And Joanne said it's hard to take benefits away, and nobody wants to be the person who's responsible for that. And so there's a healthy dose of skepticism we can have about how this is going to go down and who's going to take the fall on that. Yeah.
And as we talk about all this uncertainty, I'm wondering, for reporters who are trying to get ahead of this, is this, and this is a hard call on all these questions, but is this like a legitimate topic where you would go out and find families who now benefit from these programs, or and who are at risk potentially of losing them if some of these changes go through? Or does that feel like getting too far ahead or fear mongering? Like, how do you strike that balance as you think about, the enormous potential costs and implications of all this?
I don't know if that's just a general question, but I agree on that instinct, Michelle. I don't think it's too early. This is shaping up as a pretty big healthcare battle next year. I think it's particularly interesting if you're a reporter in one of the districts or states that are a little bit more swingy. So if you're represented by a Democrat who might be nervous about voting here, or a Republican who faced a lot of pressure over the ACA fight, those seem to me particularly salient stories to tell. And I don't know what the calendar will look like next year. I don't even know who the health secretary is going to be. I mean, it seems like it might be Robert F. Kennedy Jr. He's the nominee, but we just saw a nominee drop out today. So there's a lot that's still up in the air, as we've all said. But Democrats had tried to push this as a 2024 issue, the Affordable Care Act subsidy fight. And I know that they will push it again early next year, because healthcare is politically salient for them. It has been a big winner for their party. And the more that they can put attention on the Affordable Care Act and risks to it, the more they tend to do, the better they tend to do in the midterms.
And did anyone else want to weigh in on that? We have a lot to cover, but Sarah, you had this look like there's something I'm going to say here. Am I mistaken?
No, I really can only agree with Dan. I mean, I think of, for instance, the stories when Medicaid disenrollment happened. And so as you, Michelle, explained, like people not knowing that they were losing coverage and not knowing that maybe there was just one form that they had to fill out, or that they were eligible still, or that ACA was there. I think about those stories and how those happen in different states and how different it can be in each state or locality, because it is going to be that way as these things roll out. And I don't think it's too early, especially in states where people have already been, or I should say legislators have already passed laws that have set the stage for work requirements, for more stringent coverage. I've already seen somewhat in the chat people bringing up, you know, a few other coverage restrictions. There's plenty that's going to happen in different states now, and it seems to be the way that the Trump administration also wants it to happen, is that states will start to take much more of the healthcare decisions and restrictions than the federal government does, at least on certain things. So no, don't think it's too early at all.
And not just families, but also healthcare providers.
Yes.
I mean, that's the other, it's not just individuals who are affected by this money, it's doctors, hospitals, nurses, clinics, the entire healthcare system. They'd rather have people who are covered than people who aren't covered. And if both of these ideas about payment system changes, some of which, all of us have written for years about how we don't have enough primary care and we have all the specialty care, which is more expensive. And if they were to restructure payment, which is really hard to do because it usually means taking away from one specialty and giving it to another. But the hospitals, the safety nets, the academic centers, the private clinics, everybody is affected by both Medicaid spending and ACA spending. If you have more uninsured people, it has ripple effects throughout the whole healthcare sector, which, as we all know, is nearly a fifth of our economy. So I think it's not just talking to families; it's also talking to the people who take care of them.
Yeah, excellent point. And I want to pivot a little bit and talk about public health. Public health agencies like the CDC and state and county health departments had a wide array of arenas, from emergency response to work to prevent infectious disease outbreaks and reducing the burden of chronic disease. They protect us against environmental hazards and ensure that services are provided that just broadly ensure the public's health. But as we all know, during the pandemic, their work to prevent the spread of COVID-19 emerged as a major political flashpoint. So, Joanne, it seems like the politicization of public health is happening as never before at both the federal and local levels. And what are you seeing already taking place in some local and state jurisdictions to strip power from public health officers? And how might this accelerate or continue under the Trump administration, especially if controversial figures like Robert F. Kennedy Jr. or Dr. Oz head up major agencies, and if new appointees like Elon Musk are determined to slash the ranks of public servants and the federal bureaucracy?
There was a really profound change in the politicization of public health. Healthcare, as we all know, if you're talking about healthcare, what we've just been talking about, how much do we spend, who spends it, the role of government, that's been politicized for decades, right? It took decades to pass the ACA, many failed attempts. That we're going to be yelling about, for centuries to come. But the politicization of public health is different. There have been episodes that have been politicized, like swine flu in the 70s, which there have been things that have happened over the years where there's been some fight or controversy, but the concept of public health per se, I mean, there are fights about how much do you spend. Like the burden of public health is when it works, you don't see it. And then Congress or state legislature would say, well, we don't need to spend so much money on that. We don't need it. It's because it was working. So there have been economic fights and there have been episodic fights, but there hasn't been, what we're seeing now is an unprecedented politicization of public health per se, and a level of distrust in the public health experts, which we've never seen before. State legislatures during the pandemic cut the power of public health officials to do things like close schools, that they could different states have different formulations, but maybe they could close them short term, but they couldn't do anything. And various mandates for vaccination, school closures, or all sorts of limitations on all sorts of emergency powers have been curtailed. It has to be through the governor or the state legislature. Again, there's 50 states with 50 different solutions. But this idea that public health can't do what it thinks is necessary at the state and local level without political having their sort of wings clipped, the amount of distrust and outright, it's more than cynicism. It's really sort of a toxic hostility to people who are really just trying to keep you healthy. So, I don't think we've ever seen either the outrage over public health, and the irony is the things they're mad about, and one reason Trump was reelected is because they're mad. They're mad about steps taken to fight the COVID pandemic, most of which were initiated by Trump himself, right? The shutdown of the economy in 2020, which public health experts thought was the right thing to do, was under the Trump administration. Vaccination was developed under the Trump administration. And there's one of the many perverse things we're seeing is, just blaming the wrong people for making some of the right decisions. But basically the death threats, the hostility, lots of people quit their public health jobs. There are a lot of vacancies because of the abuse they've been subjected to. And there's at least one county in the country, I think it's Idaho, and one of you can correct me if I'm wrong, has forbidden their public health clinics from giving COVID shots. You cannot get a free COVID shot anymore in that county. You can get one if you can afford it, or there are other places doing it for free. They didn't ban them countywide, but they banned them in county public health facilities.
Is there a way that you all might recommend to maybe, cover this? I don't know,
It's a huge local story.
like, I'm sorry?
It's a huge local story because every
Right.
single county and every single city has a health department.
What storylines might you all explore?
Do you want me to
Beyond
start?
like the immediate
Someone
news
else
of like a
speak?
county stopping.
I would look at the county workforce. I would look at how many vacancies they have. I would look at the budget. I would look at what kind of restrictions, emergency restrictions there are. I would really look, workforce is a really big deal because there weren't enough public health workers to begin with, and the vacancies now. I would look at emergency preparedness in your community. I think there are limitless stories on the ways that public health has been hampered and the risk the risks from disease, from climate catastrophes, from just pretty much everything that public health has done. STD clinics, HIV. We haven't talked about HIV at all, but that's a public health. Anti-tobacco is public health. Many of these programs at the local level are your local public health officer, and the turnover has been really intense, and the vacancies are also high. Sarah, Dan?
I can really only emphasize what you said, especially about the vacancies, about the lack of support and momentum already going on, but then just adding to that some of the first things that we're already seeing from congressional Republicans is a desire to restructure the Centers for Disease Control and Prevention, which is the major funder of these local and state resources, and a desire to restructure the National Institutes of Health, which is a whole other topic as well. But there's, at least for the CDC, a lot of funding cuts within that, including to surveillance and prevention efforts, and also to, as Joanne mentioned, some HIV efforts as well. So if we think about those top priorities for funding cuts and how that trickles down, we don't even necessarily have to wait for what those cuts could be to see how that's already impacting certain communities, I think.
And Dan, I want to switch topics a little bit. Robert F. Kennedy Jr. has pledged to lead an effort to combat an epidemic of chronic disease in this country, which is welcome news to many people. But what do we know about the incoming administration's plans, and how might they contend with other parts of the administration's health agenda when it comes to potentially cutting Medicaid and food stamps and so on, that might help a population that's disproportionately experiencing chronic disease burdens?
I'll take that question in two parts. So first, Robert F. Kennedy Jr. has his Make America Healthy Again agenda. It's a riff off of the Make America Great Again slogan by Trump. And the Make America Healthy Again plan is all about combating causes of childhood illness, chronic disease. And when you ask Kennedy and his allies about things like, what are you going to do on vaccines? They always bring it back to, we're focused on chronic disease. And they have a point that chronic disease is a killer in America at a level that it is not overseas. We did a series at the Washington Post last year called Dying Early, about causes of premature death here, chronic disease, major factor. I spoke to Robert F. Kennedy Jr. a year ago for that series. So this has been something close to his first failed campaign for president, and now his potential role as HHS secretary. And I alluded to this earlier, a story that may be going up while we're on this webinar about changes to Medicare payment. One reason our RFK Jr. and his allies want to change Medicare payment is they want to make it more financially lucrative for primary care doctors to focus on prevention. Right now, the incentives are more shifted to specialty care and interventions. So I think those are all animating ideas behind what he would do at HHS. And that's an important way to look at his agenda, even with all the concerns about, say, vaccines. I've spoken to health experts who say, if you care so much about life expectancy and making people healthier, start by strengthening Americans' confidence in vaccines, given how we know they have saved lives. On this second point, Michelle, of the other agencies and RFK Jr.'s ideas on Medicaid, these other policies, I'm not sure he knows what he wants to do on these things. There is a lot that comes with running HHS that has nothing to do with anything we've talked about on this call. It is such a huge, sweeping agency with so many responsibilities. RFK Jr. has said a lot of things, many have been reported. I still haven't found detailed thoughts on a lot of the health policies that the agency does. So we might not know where he stands until he gets installed and starts rolling out some policies. I do think on something like abortion, though, there is this tension between the conservative Republicans who had an agenda for this administration, the Project 2025 agenda, the Republican Study Committee agenda, these ideas to crack down on reproductive health funding and access. It's not clear to me whether RFK Jr. is on board with that. So we will probably see some diversion from the Republican traditional plans on Medicaid and other things if RFK Jr. is installed.
And on a related note, Sarah, I'm going to ask a question of you, and I just want to mention to everybody that some folks have put questions in the Q&A. We'll go through as many as we can, but if you have a question, we're about to turn to our audience. But Sarah, Trump made banning gender-affirming care a central talking point in his campaign. And what might we expect him to do by way of executive order on this issue and also on reproductive rights, as that Dan was just talking about?
Yeah, absolutely. And I'm glad that Dan set up with talking about reproductive rights, because these two issues are in some ways parallel with the ways that within the health agencies, the Trump administration can start to erode access, care, etc., without needing congressional or court support on either of those things. And so we've seen some of these things before. And I guess I'll go gender affirming care first. So he has promised to ban taxpayer funding for gender affirming care. It would be something that CMS, so the Centers for Medicare and Medicaid, theoretically could do through rulemaking. It will surely meet legal challenges. But there's a number of other ways too that it could become the health agency could chip away essentially at access and people's safety or coverage to get these things. And so one of the big things would be the Office of Civil Rights within the Health and Human Services Department. There were a lot of language changes during the first Trump administration to the idea of what discrimination is. And those changes we could see again, things like the gender discrimination is not included anymore, for instance. And when I said that these things are a little bit parallel, abortion and reproductive rights would have somewhat the same playbook happening. Office of Civil Rights could also chip away at the language around what a person can access when they are pregnant, when they're in an emergency. The Food and Drug Administration could change the rules around, for instance, the abortion pill mifepristone, make that without needing Congress or the courts. They could try to restrict how people prescribe that, if they can mail it to patients. And once again, these will all probably meet legal challenges very swiftly, but there's a lot of things that can be done within the administration that don't necessarily need Congress or the legal system to be part of. He has promised a lot during his campaign. I know we've talked several times during this about the lack of detail on his healthcare proposals during his campaign, but he has talked a lot about transgender people and taking away rights and banning care for minors. And so we do know that this is a big priority for him. We don't know what Robert F. Kennedy thinks about this. We don't know what Oz thinks about this. They haven't talked about that specifically themselves, but we do know that this is something that Trump has promised to his voters. And so I don't think that we should take it lightly that this is something we will see very quickly.
So with that, I'm going to turn to our questions, and we have one here that's really a good follow-up on what you just shared, Sarah. Thank you. It's from Mynelius Negron, who says, who shares an interest in hearing on your opinion on DACA recipients who are already enrolled in healthcare benefits. Anyone have a sense of what?
Joanne's best on this, not to put her on the spot.
A number of states, well, there's the DACA population, which some of you know as the Dreamers, people who were brought here as children and under the Biden administration have had health coverage. It would be reasonably easy through the rulemaking process to for the Trump administration to cut that. There also, I think there's another question related to this that we might as well hit both at the same time. There are 6 or 7 states, I think it's 7 now, I think it's 6 now and 7 in 2025, who are covering not just the Dreamers, but the people, undocumented people in general who don't have access to healthcare. The states have to use their own money. Federal dollars cannot be used to cover unauthorized immigrants, but 6 or 7 states are doing that. Some for all, some for certain age groups. There's probably ways that I can't describe it a legal mechanism, but Trump has criticized this during the campaign and attacked it and blamed immigrants for the problems of our healthcare system, or Social Security, Medicare, housing, everything else. I don't know exactly what legal mechanism they could use to prevent states from doing this, but I suspect there is a legal mechanism through cutting some kinds of other funds or something punitive or restrictive. I think that the states that have taken those moves might find it hard to continue coverage of both the DACA as well as other, like Illinois is covering everybody. Many people who are undocumented have lived here for many, many years, and they have paid taxes. Not 100% of them, but many. And that includes Medicare taxes. And then they get to be 65 and they don't get Medicare. They can sometimes get some charity care and piece things together, or clinics, but some states are now covering them. And I think that probably is in jeopardy. And I think it's unlikely that other states considering it would move forward in 2025.
Yeah, thank you, Joanne. Chantal Riley asks, is it possible that the Trump administration could totally dismantle the ACA in one term?
No. But I welcome Dan and Joanne to answer this as well. This really gets to what his first term looked like, and Joanne set this up earlier, that it just is like, it's deeply unpopular to dismantle the entirety of the ACA. There's a lot of aspects of it that people do not want to see go away. And they tried several times in 2017 to do that and failed. And a lot of Republicans do not want to revisit that fight. There is, though, I will say, a pretty big burden on Republicans in general with having both the White House, the Senate, not both, all, the White House, the Senate, and the House, that they have the trifecta essentially, and that they do have a lot of power to do what they want to do. So I think that they would want to use that smartly and not revisit the whole repeal fight, but get some early victories in, that they can say, we did this for you. but welcome what Joanne or Dan would say there.
I mean, they have more senators, Republican senators now than they had in 2017 when they tried and failed to repeal. So they have a little bit more margin. You know, I at this point, can they repeal the whole thing? I don't think they want to call it repeal. I think they want to call it improving or restructuring or various other synonyms. Could it end up looking very, very, very different than it looks now? Yes, it could. You know, I also think that if they couldn't kill it in 2017, it's covering, as we've all said, it's covering millions of more people now, and it is much more popular, including among Republicans. And, you know, as President Obama at the Democratic National Convention, when he was speaking, you know, he made that sort of, you know, jokey comment about, you know, they don't call it Obamacare anymore now that it's popular. And it's true. People call it the ACA or the Affordable Care Act. You don't hear Obamacare as much. And it is popular. Even among Republicans, it's not as popular among Republicans as it is among independents and Democrats, but it's pretty darn, you know, it's not hated. Remember, the most unpopular thing, the thing that even Democrats disliked, was the individual mandate, and that was abolished. That they got rid of that in their tax bill in I think it was 2017. So I think it was passed in 2017 and effective 2019. So there's no more individual mandate. That was the thing that got people really, really mad, right? Americans don't like mandates. They don't like being told they have to buy something. The mandate's gone, and that took some of the wind out of the political sails of the repeal movement. So could it look really different? Could it be a repeal by some other name? But, you know, one thing that struck me, Dan talked about the Democrats, and the Post had a good story, I think it was yours, Dan, about the Democrats trying to build support even before the election for renewing these subsidies that we were talking about later. But one thing that struck me is we didn't all get deluged with Republicans, you know, press releases the next day saying over our dead body. I didn't get a single one. I'm not on all the lists anymore since I'm not covering the Hill day to day, but I called several reporter friends who are. They didn't get a lot of them either. I mean, there was a lot of silence. It wasn't, you know, don't even dream about it. I think the politics are still shaky. I mean, what we know, what Trump has said so far, his first priority is immigration. You know, he wants to deport 11 million people. His day one executive orders are going to be very focused on immigration. There may be some abortion stuff in there, Mexico City or something else. We've often seen early in an administration, various abortion rules. I'm not sure how quickly we will really see the strategy. And there also could be a strategy in the House that won't pass muster in the Senate.
Yeah, I don't disagree with that. I would say that if people are really interested in how ACA could change, then there are a few terms that we're going to have to get more familiar with, like reinsurance, like high risk pools. Also, we haven't brought up yet something that was popular in Trump's first administration, which was short-term plans. He extended how short-term plans could work. So they essentially are temporary plans that you can get if you say are in between jobs, something like that. Typically, they're only a few months. He extended it during his administration for a year. The Biden administration reversed that, but those plans pretty notably do not have to comply with certain ACA requirements for coverage.
It's pretty skimpy.
Yep. Yeah. So you can buy a plan and it'll be cheap and it'll hold you over as long as you are healthy and well. But then you might find out that they won't cover what you need. So we could see those coming back as well.
Tara Hale, I hope I'm pronouncing your name correctly, said that she's struggling with knowing whether she's leaning into exaggeration or fear-mongering or being realistic and reasonable in warning what could happen in the case of RFK Jr. and the way he could upend vaccine policy, and asks any suggestions on how to cover this in a way that doesn't sound hyperbolic, but really conveys the urgency and reality of what he can do.
Hello, Tara. Fly to Samoa, where the Samoan government and people struggled as a result of RFK. We're not, I should be careful. I don't want to get anyone sued. Samoa had an outbreak of disease that was vaccine preventable, and RFK Jr. had been there lobbying against vaccines. So it's an example of the value of vaccination and RFK Jr. wading in and potentially making a difference on what happened. There aren't other Samoas here in the States necessarily, but there are places where RFK Jr. has showed up, talked to lawmakers, made the case about vaccines. I think there are a lot of local stories as a result. If you just kind of trace where RFK Jr. has been and events he's held over the past number of years. And RFK Jr. too, there is no precedent for this. I keep saying this. I mean, I think it's important to underline, we've never had a vaccine skeptic, certainly not America's most famous vaccine skeptic, who has led an anti-vaccine group, in charge of health agencies like this before. So it bears all the scrutiny. And even as we're covering chronic disease and RFK Jr.'s plans, we make sure to note that he has this vaccine question hanging over his head if he is appointed to this role.
And there's lots of things he can do. I mean, we don't know who the FDA commissioner is going to be yet, unless something happened today that I missed or Dan knows. We don't, but the HHS has a lot of strings they can pull to delay or complicate approval of vaccines, funding for vaccines, because there are certain populations that get them for free. The civilian advisory committees, if you stack them with people who hate vaccines, who think vaccines are worse than disease, you have trouble. The FDA doesn't have to abide by the advisory committees. They tend to. They're not obligated to. But it's not a great look, right? If your advisory committee says this is something unsafe and terrible, and the FDA ignores them, I mean, it creates problems. Access, funding, ACA coverage. Part of the ACA requires insurers, whether you're in or out of the ACA, to cover certain preventive care things if they are approved by the government panel that looks at the validity of primary care benefits. They could change that. So timing, approval, access, financing, there are multiple ways they could interfere with both new vaccines and availability of current vaccines. They could, we've already seen some states, and this predates the pandemic, actually. There was a dip or a spike in around 2017 and 18 of some state legislators beginning to consider scrapping, and I think some states have rolled them back, the mandates for kids to enter kindergarten to be fully vaccinated. I think you're going to see a lot of activity on that in state legislatures. It's another good local state story. So what is your state doing about school? There's that wall, right? You can't put your kid in kindergarten unless they're vaccinated. That's a great opportunity to make sure kids are vaccinated. There's a lot more of opposition to that. And I think you'll see more Republican states considering rolling that back. So, I think you don't want to be hysterical, but you want to warn people what could be coming.
We have a kind of related question, and we have a lot of questions here, so I'm going to try and get through as many as we can, and maybe even go over another 10 minutes or so. Folks are free. But Maggie Ryan says, is there a sense of what RFK and Trump can do policy-wise when it comes to limiting vaccines? Or is it just about the fear of what the anti-vax messages he'll spread with with this platform?
I'll take that very quickly. So if RFK Jr. is HHS secretary, as alluded to before, he can place allies on the various committees that make recommendations on vaccines. So those might not be binding recommendations, but they could certainly be confusing ones. If the federal government is now recommending a different schedule for childhood vaccines, or maybe changing its recommendations altogether. That's one area. Another area could be slowing down the process of approving new vaccines. He could ask for more data and safety reviews. He could delay the inspections of the plants that make vaccines. Some of this is also contingent on who ends up as FDA commissioner. That could be a person who is very pro-vaccine. Unlikely, given that RFK Jr. is helping shape the appointment, but it could be someone who feels much more strongly that the vaccination process that we have is good and doesn't let RFK Jr. make as many changes or put as much pressure as he possibly could.
We have a number of questions about the threat of mass deportation, and a lot of this is just very hard to predict. But let me just kind of round up what some of them are, and maybe you all might have some thoughts on this. But David Bowen asks about whether deporting millions means there's not enough people to work in healthcare, and James Chisholm says that Governor Greg Abbott mandated that Texas public hospitals gather and disclose healthcare expenses for inpatient and emergency care for undocumented immigrants. Someone else asked, will California's undocumented community be affected through these healthcare changes, which I think you did answer, Joanne. And is it anything on how Medi-Cal might change the Medicaid program in the state? And I think there was one other question. But there was a really interesting question about whether medical providers will be asked to do things that go against their own ethics. And so this idea of, maybe not being allowed to do emergency treatment, although I don't know that I've seen that proposed anywhere. So I don't know, this is too much to tackle in a moment or two, but just thought I would share that we're getting a lot of questions about that.
I can start on that, but I don't think that I can answer all of those. But I think it was David's question about the workforce, that is absolutely a concern, and it's something that's already being discussed, and it's sort of this weird paradox that we're in where Trump is talking about mass deportations, but there's bipartisan legislation to try to ensure that people who come to the US for medical degrees, for instance, are insured and incentivized to stay here because of the workforce needs here. And so there is this tension between the idea that, yes, this is what Trump is saying, but also we badly need people in this workforce, and what happens to the workforce if he comes down on immigration as hard as he's promised to do. And then two, I think you said the next person was James, to what they were saying about penalties that could come to physicians. I think that's going to be a major theme that's going to come up in general in just a lot of the policy proposals that Trump has had, or that Republican state legislators have had, with regards to undocumented immigrants, with regards to abortion and reproductive care, gender affirming care. I think if there's one theme that we can have thinking as journalists about what we're doing here and how we're covering these things is when are physicians allowed to practice medicine, and when will they stop, and what will the repercussions be? We've already seen early repercussions of physicians leaving areas where they cannot practice medicine safely without penalty. And so if you're thinking within your own state, for instance, about how to cover this, that's something that I just think is going to continue to be a massive theme, that physicians are not going to necessarily want to endanger themselves or their patients. And so we could see the disparities grow a lot in these states as well.
There's also the question of people who are afraid of being deported are going to be living in the semi-shadows, and that may mean not seeking health care when they need it. Right now, there's no questions asked about your domestic, your immigration status if you go to a clinic or an emergency room or healthcare, and there's no INS people hanging out waiting to deport patients, and that could change, or the perception could change, right? Even if it doesn't get that extreme, and there are signs that it actually will, we don't know yet. The fear may really prevent people from getting the healthcare they need, even in emergency situations.
We'll take a couple more questions. Mary James Young says, how do you think this will impact pregnant women on Medicaid and home visiting programs that support at-risk families?
So we didn't bring up Medicaid postpartum coverage at all before, but that's an interesting one. I know Joanne could speak to that as well a lot. The Biden administration extended postpartum coverage for women, for pregnant people in Medicaid up to 12 months after their pregnancy, after their childbirth. And not every state has taken that up. There's several holdouts. I know Arkansas is one of them. That's something that I don't think many Republicans necessarily want to rescind or reverse. It's popular. It's been working, especially for the states that have had dismal maternal and infant mortality rates. This has been an important part of trying to reverse that. So I don't know that there's necessarily a high priority for a lot of Republicans to tackle that. And Trump himself has tried to illustrate himself as someone who is, a leader on IVF and on childbirth and in families. So, but Joanne also, I think, can speak to this a lot more too.
I believe it's 40 states that have taken up the option that Sarah just said, that the federal Medicaid program lets states You don't have to get a waiver, you don't have to get special oppression. There's a blanket, states are allowed to extend postpartum care for a year under Medicaid. And some Republican states have embraced that. We do have a maternal mortality crisis in this country. It has been recognized on a bipartisan basis. This holdout states tend to be Republican, but there are a number of Republican governors who have, including in the Southeast, including in the states that aren't doing the rest of Medicaid expansion, they have opted for this. So I don't think that's where you're going to see, you might see a few states flip, but I don't think that's where you're going to see the major impact of Medicaid changes. It might not be zero, but I don't think it's gonna, that'll be repealed and all the postpartum coverage will go away in the next short term.
And to the second part of that question, at home care, and I may have gotten it wrong with what you said, but in general, at home care, long-term care was a sort of late arrival for both Trump and Harris to their campaigns, and their recognition that they needed to talk about this and how much of a financial burden it was to families. Trump has not offered so many details about how he would provide for or supplement at-home care, long-term care, et cetera. But he has said that he would do tax credits in Medicare for that. And so I think that was a recognition from both presidential candidates of how much of a financial burden this is for so many Americans. But there's not much detail yet on how that would work and how it'd get paid for.
And in terms of the home and community care that's already allowed, that's already happening, I don't know that they would try to say you can't spend money on that, but if there's less money to spend, then states would decide where they want to spend it. Some would maybe, do more home and community care if it's cheaper than institutional care. Others might, if they have less money, they're going to decide how to allocate it. It may, I don't think that you're going to see that option taken out of Medicaid completely, but there may be less. If there's less money to go around, we don't know how states are going to decide how to spend the money. Typically, when they're talking about cuts to Medicaid, they're not talking as much about the older people in long-term care. Medicaid is the major payer of long-term care in this country, of nursing homes. It's the single biggest payer. The home and community alternatives to nursing home care is often less expensive, and also people want that if they have family who can take care of them or community that can take care of them. So more of the cuts have been the community in general, the rest of Medicaid, health services for the non-nursing home eligible population. We're not hearing as much cuts because middle-class people end up spending down their assets, and then grandma has to go into a nursing home that Medicaid pays for. We're not hearing as much political conversation about cuts to that portion of it, although again, we don't know how things shake out. If there's a whole lot less money, how states are going to allocate it. But the conversation has not mostly been about the long-term care population.
And Richard Eisenberg, and I think maybe we'll have to make this the final question. And I apologize to our audience because there's so many great questions here. But he asks, Trump and Oz seem to want to push Medicare Advantage. How do you see them doing it? And could it be the default for people in Medicare or something else?
Can jump in a little there because that is something that has been floated by a lot of Republicans, not just Trump or Oz, but people who've been running for Senate seats, House seats, Republican think tanks, is the idea that Medicare has gotten too costly, and the way to manage that is to move more people over to Medicare Advantage. And I don't want to lend too much credence to things that Trump has distanced himself from, like Project 2025, but some of the proposals that were in that and other things is somewhat automatically enrolling people into Medicare Advantage rather than the Medicare program. So I absolutely think that it's a high priority for not just Trump or Oz, but several congressional Republicans as well. It's seen as something that can help manage costs of Medicare. And it's sort of posited under this umbrella of competition makes lower costs, and the idea that if you have private insurers competing on giving people Medicare Advantage plans, then the cost will be lower in order to stay competitive with those enrollees. Of course, the problem is there that a lot of times those costs will be low when you start, but then you'll find out that you don't get covered for certain things, that the hospitals around you are not eligible under the program that you have. these Medicare Advantage plans heavily recruit people to go into them rather than the government Medicare. And then people find out afterwards that maybe the providers who are near them are not under that program, or certain things that they need are not covered with that program.
Well, with that, we're going to conclude the webinar. I want to thank Dan, Joanne, and Sarah, and to the audience for all their great questions. And I also want to thank the members of the Center for Health Journalism team who contributed to this program, content editor Ryan White and communications strategist Abs Mandar Bishu. We'll be emailing you a survey asking for your feedback on today's program and for your ideas and other topics of interest. Please take a moment to complete it. We also urge you to help support these webinars. You can find more information here on how to do it. And I will mention that we are partners with Newsmatch this year, and any donation can help and will be doubled by Newsmatch. And we're suggesting increments of $20 to celebrate our 20th anniversary. And of course, we'll be archiving this webinar a little later today at centerforhealthjournalism.org. Thank you so much for joining us.